Welcome back. So this is part C of lecture 7. We're looking at immunity or immunology. So this is still blood physiology. So we've been discussing immunity with regards to blood physiology. So to say immunity, you have white blood cells that are involved there. And white blood cells are part of the elements of blood. So took a bit of time to discuss immunity because there is a lot of information. So the first part, we just looked at innate immunity. The second part of this video, we're looking at cell-mediated immunity, and now we are just discussing humoral immunity. So part of humoral immunity is part of part B of the video. We have part A, part B, and part C. So for you to grasp all the information in immunology, you just need all the videos. So you need to watch everything from part A, part B, and part C. So if I had made just one video, it was going to be a long one. So it was going to be boring. So that's why I just split them into 3 parts so that you are able to follow nicely. Okay, so we're looking at the functions of antigen antibody complexes. So after you have antigen antibody complex, how does that help the body with regards to immunity? So we said the first function of antigen antibody complex is viral inhibition. How is it going to inhibit the viruses or bacterial inhibition to some extent? Is by binding to the antigens that are found within the plasma membrane of the virus or the bacteria. So you can see that these antibodies, they have the binding site. So you have 2 binding sites. So we said for them to destroy that pathogen, the 2 binding sites, they need to bind to the pathogen so that you have a complete antigen. Otherwise, if there's only one side that is binding with the antibody, then you have a partial antigen, which are also called heptans. So for heptan, for it to be complete, it also requires a carrier protein. This carrier protein could be a protein that is coming from the same pathogen, or it could be a protein that is presented by normal cells. So if it's a protein that is presented by the normal cell, the antibody will destroy the antigen and the normal cells. Yes, so you should take note of that. So the first function of antigen antibody complexes is viral inhibition. So you have antibodies react with molecules on the viral surface and prevent the viral attachment to cells. So there will be viral inhibition. So these viruses can't attach the cells and invade the cells. Why? It's because they are antigen that have got a binding site to the cells. They are already bound with antibodies. So it's inhibited to infect other cells. The other function of antigen antibody complex is neutralization of toxins. So you can have toxins maybe from reptiles. It could be a snake. When a snake strikes you or bites you, there is some venom that will be injected, and those venom contain toxins. So the antibodies, they have sites where they can bind to those toxins. So because these are antibodies that are binding to toxins, they're called antitoxin. So you have antitoxin. So certain drugs that can be given to a person with toxins are antitoxins, which are basically antibodies specific for that toxin. So you need to know the shape of the toxin to produce an antibody specific for that toxin. Otherwise, if there is mismatch of antigen antibody, those antitoxin won't work for that toxin. So there is neutralization of the toxin. Why? It's because the antibodies can come and bind to the toxin. Then this toxin can be phagocytosed and to be destroyed by macrophages or any phagocytic cell. So neutralization of toxins, antibodies called antitoxins combine specifically with the toxins, thereby neutralizing them. Then the other function is agglutination. So agglutination, just like we have agglutination of blood, if you mix, if there's mismatch of blood groups and then you transfuse blood that is not compatible to a patient, you find that there is agglutination. Why? It's because there will be antibodies that will be specific for the antigen that is found within the plasma membrane of erythrocytes or red blood cells. So form agglutination or clumping of cells. Why? It's because the antibodies, they have got binding sites. So they have more than 2 binding sites. So you have 2 sites where they can bind to the antigen. Then they also have other sites where a complement protein can bind for it to be activated. And also it has got a binding site for macrophages. So they are able to bind a lot of these pathogen and then just clump them together or agglutinate them. So you have agglutination as a function of antibody-antigen complexes. So you have agglutinins that combine with antigens on the cell surface and bind the cell together or restrict movement. So they're going to restrict movement of these bacteria or viruses, and then the macrophages will be able to find them and phagocytose them after agglutination. Then precipitation. So the antibodies are also able to bind to antigens that are dissolved in fluids or plasma or interstitial fluid, whatever it is. So the antibodies will go and bind to those dissolved antibodies, then they'll precipitate them. So there'll be precipitation reaction because of the antibodies binding to dissolved antigens. So these antigens can just be moving as dissolved antigens, but the antibodies are able to bind to them. So these antibodies that are binding to dissolved antigens, they are called precipitins. Precipitins because they will result into precipitation. So precipitins combine with dissolved antigens to form a lattice-like arrangement that precipitate out of the solution. So you have precipitation out of solution because of these antibodies that are binding to the dissolved antigens in plasma or whatever it is. Then the other function is opsonization. So opsonization is going to facilitate the function of phagocyte because it's going to coat the pathogen. The antibodies, they're going to coat the pathogen, so they can't bind also, they can't do nothing. So they can easily be phagocytosed. So you have opsonins, we have opsonins. So these opsonins are proteins that are involved in opsonization of pathogen. So opsonins encourage phagocytosis by forming a bridge between parasites and receptor sites on the phagocyte. So they're going to attach the parasite or the pathogen, then they're also going to bind to the receptor on the macrophage. So this parasite will be somehow bound to the macrophage, and they need to be easily internalized by the macrophage because it can't present its antigenic proteins. So it can't destroy or it can't harm the macrophage. So it can easily be phagocytosed after opsonization. So those are the functions of antigen antibody complexes. So there are different types of antibodies. Like we say that the antibodies are determined by the constant segment of the antibody. So this constant segment, you have different types of antibodies. So examples, you have IgA. Then this IgA, you have a bacterial toxin. So the IgA will be produced, and this IgA will neutralize the bacterial toxin. So you can see the cell with the receptor for the toxin. But this antibody will go and bind with the toxin, then it will result into precipitation of this particular toxin. Then they will bind to the receptor of this cell. Then this cell will be able to internalize the toxin. It will fuse with the rhizosome, and then they'll be destroyed. The toxins will be destroyed. So this is called opsonization. I mean, this is called neutralization. So the toxin that is produced by a bacteria will be neutralized by attachment of the antibody to the toxin. That will bring about neutralization and then internalization later on. Then an example of IgG, which is different from IgA, that is responding to the toxins. The IgG, it's a bigger one. So, for instance, you have bacteria in extracellular space. So these are bacteria in the extracellular space, and then you have a macrophage here. So this IgG can go and bind to the bacteria. So you can see there is opsonization taking place. The IgG bound to the bacteria, different sites. Then the IgG can also bind to the macrophage. That will result into internalization of the bacteria by the macrophage, then it will be destroyed after opsonization. Then another example is IgM. So remember, there are 5 antibodies: IgA, IgG, IgM. Then there's also IgE and IgD. So these are just examples. So IgM, an example, these are antibodies against antigens that are also found in the plasma membrane of red blood cell, like I've already said. So these will form a complex that looks like a star. Why? It's because the IgM, they are able to bind to other IgM, and then they'll have this complex of antibodies. So as much as they are smaller than IgG, but they are not able to cross the placenta to go to the maternal circulation. Why? It's because they have a tendency to attach to one another to form this complex of antibodies, which is so big, it can't pass through the placenta to go to the fetal circulation. So you have the bacteria in the plasma, yeah, IgM going bind with bacteria. So you can see they're coming in numbers to come and bind, and then also with the help of the complement system that will complement the function of the antibody. After activation, it can also result into destruction of the bacteria, because once it's activated, the complement system, once they are activated, we said we have those factors like the active complement number 5, 6, 7 to 8. They'll form perforins that will be inserted within the plasma membrane of the pathogen. Then the integrity of the plasma membrane of the pathogen will be lost. Things can move into the cell, and then that cell will rupture, or that pathogen will rupture. So you can see here that the antibodies, they are working in conjunction with the complement system. So the complement system will insert the active form of complement protein that will allow things to move into the cell and other things to move out of the cell. And then you have these IgM that are also bound to the pathogen. Then it can easily be internalized by macrophages or other phagocytic cells. Primary response to infection, the first antibodies that will be produced are the IgM. So you can see here, the IgM, this is a primary infection, meaning that you are presented with this antigen for the first time. Then you have cellular mediated immunity, activation of B cells and T cells after antigen presentation via the histocompatibility complexes 1 and 2, as I've already explained. Then there will be activation of B cells. Once the B cells are activated, you know to say the B cells are the ones that are also presenting the antigen to the T cells. And then the T cells will produce cytokines and other interferon that will activate the plasma, the B lymphocytes to be activated, and then they'll undergo proliferation and differentiation. Then you have a clonal proliferation of B cells into plasma cells. So you have a lot of plasma cells. Some of them will become memory B cells. That's when you have another infection, they can be transformed into plasma cells and produce antibodies specific for that antigen. So the first antibodies that will be produced are IgM by the plasma cells. So you can see the IgM being produced. Then the second type of antibodies that will be produced are IgG. So as the IgG production is increasing, then the IgM will be reducing. So the primary response to infections, the concentration of IgM will spike first, then it will be taken over by the function of IgG. Because IgG is the one that is specific for viruses, bacteria. So you can see, this is the production of antibodies. The first response. Then you can see here, this diagram is showing you the primary immune response to antigen A that produces antibodies to A. So you can see that you have the antigen A that is out into activation of these lymphocytes, the B lymphocytes, T lymphocytes, the B lymphocytes will be activated. They'll start producing antibody A against the antigen A that is specific. So that you have exposure here to the antigen A. It takes a bit of time for cell-mediated immunity to kick in. So first you have the innate that is taking care of this antigen because that is not specific for anything. But later on, a more specific immune response will be triggered by activating specific cells. So the B cells, once activated, they'll become plasma cells. They'll start producing immunoglobulins. And I've told you to say the first immunoglobulins to be produced is IgM. Then later on, you have IgG. So there is production of these immunoglobulins that are specific for this antigen. That will go and bind to the antigen to facilitate opsonization, neutralization, precipitation, all those functions. Then with time, when the infection is reducing, even the production of the antibodies will also be reducing. Remember, you have the T suppressor cells that are also shutting down the function of these lymphocytes. So it will reduce to the 8. Now, when it's reducing, there is also a pocket of memory B cells and memory T cells in store. So you have these pockets of memory B cells, memory T cells. So at day 28, you can see that there is exposure to antigen A and B. So antigen A were exposed before, but for antigen B, the first time we're getting exposed. So you're going to have two responses. So you have the secondary immune response to antigen A because you already had the memory B cells and T cells. It will be very quick to respond because those memory cells will be activated into the active plasma cells and the cytotoxic T cells that will attack the antigen. So it will be very simple for you to take care of that infection. So find that there will be a spike in the production of these antibodies that are specific to the antigen A because you already have that in the memory. Then later on you start reducing. So you don't have to worry so much about this antigen A because you already have the immunity. You are immunized against it. Then since the antigen B was being introduced for the first time or it was being exposed to this person for the first time, so you're going to have the primary immune response, whereby you have production of antibody B. So it will take a bit of time. So you can see here, the exposure was at the same time, but you've responded so quickly for the antigen A because you were exposed here initially. So this is the first response, this is the secondary response. Primary, secondary response. But you're having a primary response to antigen B. So it will take a bit of time for you to present the antigen to antigen by the antigen presenting cells and then to mount immunity against it. So you have the more production now of antigen B. So this is now the primary response to antigen B. But if you are also exposed again at another point with antigen B, because now you have developed an immune memory. So you have B memory cells, B memory cells, and T memory cells that can respond next time you have antigen B. So you have a secondary immune response. That will be very quick. It doesn't take time because you already have it in the memories of these cells. Okay. So a bit of information on the actual immunoglobulins, immunoglobulin classes. Like we said, there are 5 major classes, the IgE, starting with the IgG. So the IgG is the largest and the most diverse class of antibodies, 80% of all antibodies. So 80% of the antibodies that are being produced are IgG. But remember, the first antibodies to be produced are IgM. Then that production will overlap with the production of IgE. So the IgE will now spike. So they are majority in terms of the antibodies because they're the ones that can attack viruses, bacteria, fungal, toxins. So they are not very, very specific because they can bind to a lot of things. So that's why they're common. So the IgG antibodies are responsible for resistance against many viruses, bacteria, and bacterial toxins, like I've already said. So can cross the placenta they can cross the placenta and maternal. IgG provide passive immunity to fetus during embryological development. So as the embryo is developing or the fetus is developing, before the fetus starts producing its own antibodies, you find that the maternal IgG is able to cross the placenta to go to the fetus or to the embryo to protect it. So you're talking about passive immunity. The anti-rhesus antibody produced by rhesus negative mother are also IgG antibodies and produce hemolytic disease of the newborn. So you have erythroblastosis fetalis or hemolytic disease of the newborn or the neonate. So we discussed this, the anti-rhesus factor. You have the D antigen. So you find that if a woman is pregnant for a rhesus positive when she's rhesus negative, if for some reason there's mix-up of blood from the fetal to the maternal, there's introduction of fetal blood to the maternal, then the maternal circulation, you have these erythrocytes that are coming from the fetus and they have antigen D, the plasma membrane. This antigen D, they'll end up immunizing the mother. So the mother now there'll be activation because those are foreign proteins within the mother. So there will be activation, antigen presentation, and also activation of B cells. B cells will be activated into plasma cells. They start producing IgG. So these IgG antibodies, they are able to cross the placenta. So they can go to the fetal circulation now. They will go and attack the fetus. That will result into hemolytic disease of the newborn or erythroblastosis fetalis, like we've already discussed in the other lectures. But you know to say that this is very severe with the second child, because the first child, the mixing up of blood is taking place during labor or whatever it is. It takes a bit of time for cell-mediated immunity to develop. So by the time the mother is being immunized, she will have given birth. So the first pregnancy is not affected. But the second pregnancy, if it's also rhesus positive, then to be affected because there'll be severe damage of the fetal blood that can result into hemolytic disease of the newborn, which is a special type of anemia, then can also result into jaundice because there'll be accumulation of bilirubin. So this bilirubin, the liver of the fetus is not yet developed. So after birth, the baby doesn't have the gluconeal enzyme that can conjugate the bilirubin. So you have a lot of indirect bilirubin that will cause now that will cause discoloration of the skin. So the skin becomes yellow. Why? It's because the bilirubin is also sensitive to light. So once you have bilirubin under the skin and then it's exposed to light, it will change color and then to become more yellow. Okay, so it proceeds. And then we have IgE. The IgE attaches as an individual molecule to the exposed surface of basophils and mast cells. So the IgE is involved in allergic reaction and also parasitic infections. So this IgE is able to bind the basophils. So as the basophils are moving, they can move with the IgE bound to them. Not that they are the ones that are producing the IgE, but the IgE has got a binding site that can bind the basophils and mast cells. So they are going to help the basophils and mast cells to internalize pathogens, because these are also involved in phagocytosis. They can also stimulate B cells to produce histamine and also heparin. Histamine is a vasodilator, and also to produce other cytokines that can attract other cells. Then when an antigen is bound by IgA molecule, the cell is stimulated to release histamine, like I said, and other chemicals that accelerate inflammation in the immediate area. So you can see that they're producing histamine, histamine vasodilator to promote inflammation because of the movement of fluids from the cardiovascular system to the inflamed areas, and also movement of white blood cells to those areas. So the IgE is also important in allergic response for elimination types. Then moving on to the IgD, IgD. The IgD is an individual molecule on the surface of B cells. So this IgD is found on the plasma membrane of B cells. So in as much as they are producing antibodies, they also produce antibodies that will be incorporated within the plasma membrane of these cells, because remember, the B cells are also phagocytic in nature. So there are special types of antigen presenting cells. So some of the immunoglobulins that they are producing, they can be incorporated within the plasma membrane. That will help them to bind to other antigens and internalize those pathogens, process them, present them on the major histocompatibility complex class 2 to the T cells, activation of the T cells, and then the T cells will produce other cytokines that will activate the B cells to differentiate, proliferate, and then you have more plasma cells that will produce antibodies against that pathogen. So like I said, IgD is an individual molecule on the surface of B cells where it can bind antigens in the extracellular fluid. So it's able to bind to the antigens. Binding can play a role in the sensitization of B cells. So sensitization or activation of B cells, the binding of these antigen to the B cell can activate or sensitize the B cells. IgM is the first class of antibodies secreted after an antigen is presented or exposed to this or encountered. So the IgM is the first class of antibodies secreted after antigen is presented. Yes, so I've already mentioned this. When you're looking at the primary response, the first immunoglobulins that will be produced are IgM, then later on IgG. So the IgM concentration declines as IgG production accelerates. Same information. Plasma cells secrete individual IgM molecules, but it polymerizes and circulates as 5 antibody star base. So like I said, the IgM, they're not as big as the IgG, but because they have a tendency to polymerize or to attach to one another, and then they'll start moving more like a star. So that is called 5 antibody star base. The anti-A and anti-B antibodies responsible for agglutination of incompatible blood types are IgM antibodies. So those antigens that are found within red blood cells, the immunoglobulins that are specific for those are called IgM. So the IgM are the ones that can cause blood agglutination because they're the ones that are specific for the antigens that are found in the plasma membrane of red blood cells. So the anti-A, anti-B antibodies, they are IgM in nature. Then the IgM antibodies may also attack bacteria that are sensitive to IgG. So IgM, IgG, all these, they can attack the same bacteria because they can have similar binding sites. So the IgM can also attack the bacteria that is insensitive to IgG. So there are certain bacteria that are insensitive to IgG, then the IgM can attack, not that they have a similar binding site. So IgM antibodies may attack bacteria that are insensitive to IgG. So IgG is not binding to this bacteria, the IgM can come in and help. Then should be the last one, the IgA. The IgA is found primarily in glandular secretions. So the glandular secretions, they have IgA. Like I said, mucous membranes. So you have mucus, tears, saliva, and semen. They will contain a lot of IgA. So remember, the first line of defense against any pathogen is the skin and mucous membranes. The skin and mucous membrane, they can secrete proteins, and these proteins, it could be an IgA, but it's not that these epithelium cells, they are producing the IgA. The IgA is being produced by the same plasma cells, but they are able to absorb the IgA, then they'll process that IgA, then they'll secrete the IgA in the secretion. That will provide protection of the mucous membrane and also the skin. So they are also found in mucus, tears, saliva, and semen. So attack pathogens before they gain access to internal tissues. So IgA antibodies circulate in blood as individual molecules or in pairs, so they can move in pairs or just an individual IgA. Epithelium cells absorb them from blood and attach a secretory piece. So they will attach a secretory piece to the IgA, which confers solubility before secreting IgA molecules into the epithelium surfaces. So before they secrete these IgA into the surfaces, you find that the epithelium cells, they are able to attach a secretory piece or protein that will render it solubility, so that it becomes soluble in these fluids after secretion. Okay, the fraction of adult level of serum immunoglobulins. So this is a similar example where I told you to say that the first immunoglobulin that will be produced is IgM and then IgG. So here I'm just showing the passive transferred maternal antibodies, because from the maternal to the mother, IgM, they don't move because they move like a 5 antibody star based. So they are so big for them to cross the placenta. So when you're talking of passive immunity, so you can see here the diagram that is showing a fraction of adult level of serum immunoglobulins. So at conception, you can see that you don't have much of these antibodies. After conception here, you have the embryo that will start developing. This embryo, there will be passive immunity that is coming from the maternal circulation. So the mother, as she is exposed to other antigens, she's producing different types of antibodies, all the 5 different types of antibodies. But the antibodies that are able to pass across the placenta are IgG. So you can see passively transferred maternal IgG. This is passive immunity that is moving to the fetus or the embryo that is developing. So the amount of these antibodies will increase to protect the embryo before birth or the fetus before birth. And then as you're approaching birth, you find that the IgG will start reducing. But again, there's also newly synthesized IgG. So this is the IgG that is being produced by the same fetus. So the fetus can also produce the IgG because there are certain pathogens or microorganisms that can cross the placenta to go and attack the fetus. So even before birth, the fetus can be exposed to microorganisms or pathogens. So it will start producing its own IgG. So you can see here you have passive IgG from the mother or maternal circulation, and then you have newly synthesized IgG by the fetus itself. Then you can also have newly synthesized IgA by the fetus. Then after birth here, you can see that the fetus will start producing more IgG. You can see here that you have this IgG that is being produced by the baby now. This is after birth. But there is this portion where you have transient low IgG levels. So it's transient low IgG levels because the fetus after birth, it will continue producing IgG. I mean, this is IgM actually. This is IgM that is being produced by the fetus. So the IgG is this one. This is IgM that is being produced by the fetus. So you have newly synthesized IgM, but the passive immunity is the IgG that is being passed to the fetus. Then after birth, the mother is no longer passing that IgG, then it will reduce. It's reducing, but you can see here, even after birth, you have concentration of IgG that is coming from the mother. This is where you have breastfeeding, because the mother is still breastfeeding, so she's still passing on the IgG in the milk. Then you can have this portion where you have a transient low IgG levels. Why? It's because now the baby is just getting neutral of these antibodies from the mother. And then after birth, the baby will start producing her own IgG. So you can see the newly synthesized IgG here. So this is why you need to protect the baby. Why? It's because the concentration of IgG here is low. And the IgG is the one that is functional against the viruses and bacteria. So the baby needs to be protected here. And then you can also see as the fetus is developing as the baby is developing or the fetus is developing almost due, there's also production of newly synthesized IgA. So you have this production of antibodies. So this is the production of the antibodies, IgA, IgG, IgM. Then there is the transient low IgG, because now it's not being passed to the baby after birth. There's just a neutral that she's getting from the milk. Then she'll start producing her own. So this portion, the baby is prone to infections. So you can see birth here, these are years, these are months. So first 9 months after birth, the baby needs to be protected. Then you can see after that, she'll start producing her own IgG. Then the immunity will improve from year 1 to year 5. Okay, this diagram is just summarizing everything that we discussed, so I'm not going to discuss that. So everything you can see, interleukins and everything, the cells out there communicating. So this is just a video on immunology, just for you to appreciate what I've been just discussing with you. So you can see the skin, the first line of defense. So if the skin is broken by sharp objects, result into bacteria that can gain access into the body. So this bacteria will be phagocytosed by white blood cells. So you can see the white blood cells that will respond, and this bacterium will be phagocytosed. So you can see there will be activation of macrophages. They will extend their flagella so that they can trap a lot of this bacteria. The bacteria itself can produce chemicals, and these chemicals will get macrophages and present species the presentation of interhistocompatibility complex. They produce cytokines that will bind to other macrophages, and they'll activate macrophages, and then they'll also tell the cells where the infection. So it will also one location of other where the infection is taking place, or and they're going for the bacteria. So these macrophages are unable to destroy all the bacteria. So you find that there are certain attributes that will relate to lymph nodes. So that's why when you have infection, lymph nodes are reactive to more lymphocytes. So you can see the lymph node reactive. So they will stimulate action of lymphocytes. So you have the receptor. They will know the healing has embedded. But after an embedded like this, then give lymphocytes starts the cell of activation and to activate the B cell. More the bacteria. So you can see the cells to attack the bacteria by producing lymphocytes interferons. They also treat things. So you have autoimmune disease. So in the cells will start attacking normal cells. So immune cells now is again. You can see that being a macrophage. So in autoimmune disease, in autoimmune, like for instance, rheumatoid arthritis, where you have inflammation of the joints. So the inflammation that's called the only immune cell is normal tissue. So that is how to do. Okay, so that's one can mostly be done in outdoor and small people. So I hope you learned something, you enjoyed immunology. If you still have questions, I mean, feel free to contact me and ask those questions. Remember, we need to interact. You as a student, me as your lecturer, you do your research, you study my notes, you study textbooks, the recommended textbooks, and then when you still have some questions, you can still use these platforms that we have, contact me and ask those questions. Even the interactive classes that we've been having, you have that free time to ask those questions. So I hope that will be done.